esteemed PhD candidate. The College of Deans of this university, represented by us, has read your PhD thesis and the propositions that go with it, and we are ready to hear you defend it. Please take your seat.
Thank you.
Does anyone in the audience wish to exchange ideas with the PhD candidate? If so, please take a seat on the table. You have about 7 minutes for questions to a candidate.
Thank you very much, Madam Rector, for this opportunity to exchange some views with the candidate. My name is Jaap Koot. I'm the Dean of the Learning Community Global Health in UMCG. And I'm very happy to discuss this thesis that is very important because it is a further study into the perception of patients on this chronic disease that is increasingly important in Indonesia and all over the world. So it is a big achievement that we get more insights into the patient's ideas. I would like to exchange with you about the parallels between health literacy and your score for diabetes distress. Health literacy is the ability to understand health information, to discuss health information, and to take decisions about health. And in fact, you mention often in your thesis symptoms of low health literacy, like not be able to understand the doctor's explanation, forgetting what you mentioned, or needing another person to accompany you for a medical consultation because you are not able to exchange with the doctor. You explain also on page 51 that many people don't understand the essentials of therapy. So I looked at your tool, the diabetes distress scale, and I found many parallels with the health literacy scores that we apply in Europe and all over the world. So also you found that high DD score is associated with high mortality, and it's the same for health literacy. So I was looking at some of the parallels in the causes of low health literacy and the causes of high diabetes distress. And for low health literacy, it is low education, low income, not having power about your personal situation, low socioeconomic status. So I was looking in your tables at parallels, and I was trying to find education levels. So I would like to discuss with you your table on page 30, and I would like to get more explanation on your scoring of education levels. You mentioned there are only two groups, up to senior high school level, which is 72.2% of the patients, and university degree. While in health literacy we look at a more differentiated table of education levels and look at primary, secondary, and higher levels. So I would like to know from you, why have you chosen this cutoff point? And you mention on page 103 even that you consider secondary school as a low level of education, while in general we consider that not. We only say primary school or lower is low level of education. So why did you choose this cutoff point? And do you have maybe from your research other types of graduation, grading the different levels of education, and can you maybe refine your ideas about what the influence is of level of education on the diabetes distress scale?
Lord Opponent, thank you very much for your questions. Yes, we divided our participants into two groups. The lower level education, it's the participants up to senior high school, and then the university degree. Why? Because in Indonesia, it is very heterogeneous and then diversity. So the senior high school in Java may be different with the senior high school in the remote area in from my area. It's one of the reason. And then also, during I did my study, I communicate with the participants from senior high school, primary high school, and also senior high school, junior high school. It is sometimes, I need more explanation for that group of participants compared to those participants in university degree. So that's why it is the first study, like we can call it infrastructure study or introduction study for diabetes distress scale. So we only divide it into two groups. So it's more higher number and more comparable number. I also tried I did my analysis, I also tried to divide it more primary high school, junior high school, and then the participant without attended school. Yeah, they say that 2 participants never attended school. So I try to divide them into more detail, the background or education background, but our data. It's not really give a picture, not really give a description for Indonesian situation at the moment. But thank you very much, Dr. Jam. I think it is also one of my notes for my next research. I also interested to compare the senior high school and then the junior high school, and also the participants without never attend a school. Yeah, and then we also did the analysis to compare both of them. The participant with lower level education and then the university degree, there is no differences about their distress scale. When we compare both of them, I have a reason for that one. I think we did our data collection in the same way, like health literacy. We sit together with them and then we explain about the study one by one, I or my research assistant. So, and we also give them opportunity to ask questions if they didn't understand about our explanation about that one. So the health literacy, we become a health literacy partner to help them to understand our instrument, to understand our purpose of our study, and also to understand what the research question in the study, and then why they are involved in my study.
Okay, thank you.
Thank you very much for your question. The time is over.
Thank you.
Thank you very much.
Thank you.
We will continue. I now call upon Professor Wilford, Professor in Pharmacotherapy and Clinical Pharmacy here in the University of Groningen and also member of the Assessment Committee. Professor Wilford.
Esteemed candidate, saya ingin menyampaikan selamat atas thesis PhD yang sangat menarik ini. Dan saya juga ingin memberikan selamat kedua orang tua kamu karena mereka memiliki anak yang sangat berbakat. And of course, I would also like to congratulate your supervisors with this very impressive thesis, which even resulted in, amongst others, the DDS-17 Bahasa Indonesia, which is already recommended, its application at least, by the American Diabetes Federation and the International Diabetes Federation. But interesting thesis leads to questions, of course. And chapter 2, in the discussion on page 33, 34, 35, you discussed the substantial difference between floor and ceiling effects in your study on the DDS-17 Bahasa Indonesia, and explain this, for instance, by the characteristics of the participants in the test panel. What would be the optimal test panel, and what differences would you expect there?
Highly learned opponent, terima kasih banyak atas pujian Anda. Thank you very much for your compliments.
Sama-sama.
Also, congratulate my parents. About the floor and ceiling effect, it's one of the interesting topic in my area because mostly the Indonesian participants, when we met them in health facilities, especially in the hospital, it is like my experience, they would willing to help us, but without analysis. Sometimes they say, okay, no problem, no problem, no problem, because they say, I have a son, I have a grandchild also a student need researchers, need helping from others. So in this chapter, there is many participants reported the floor effect. It's because of that. Participant A, they say, okay, I'm willing to help you because I'm really tired. I'm waiting for 7 hours since in the morning. I woke up 5 a.m. and then now, I need more energy to think, to analyze the questionnaire. So it's no problem for me. It's no problem, no problem, no problem. And then another thing, my husband waiting me in the parking garage, so I have to hurry up to meet him because I also think about my kids in house, something like that. So mostly of them say no problem for its items. Compared to participant with university degree, like I have 3 participants and I think he is a PhD. He is PhD. We talk more about research, and then he gave more explanations about his feeling, about his feeling, and also give advice for my data collection and research.
But what would be your ideal test panel? Who would you like to have in your test panel? Because now you are more or less restricted, as you describe. What would be the ideal?
To be honest, I don't know at the moment.
Okay,
Yes.
I understand that.
Yeah.
But you also described that there was help needed in communication, especially in the Sundanese or the Javanese language. Does that implicate that you also need a DDS-17 in Javanese or Sundanese?
Okay, interesting question, Professor. Thank you very much. It doesn't mean like that, because all the Indonesian, I think we use Bahasa Indonesia as our national language. For like the local language, like Java or Sunda or in Sulawesi, we also have our own local. It's like respect, because mostly in Indonesia, the diabetic patient is the elderly patients. So when we come to them and then, would you willing to participate in my study? It's to build the communication with the participants. So it's like a respect. Oh, okay, I would like to help you. Compared to, I met the elderly participant and then, Anda mau, I use Bahasa Indonesia, formal Bahasa Indonesia, sometimes they say,
I can really understand that, because I'm living in Friesland and there the older people also prefer to communicate about feelings in their own language. So would it make sense then to develop this in their own language, to allow them more freely to communicate what they feel?
Yes, it is possible, but I think it's also, we have to think about the time and then also the cost for research. I give some alternative way for that. I collaborate with many research assistants, and then they can explain about the Bahasa Indonesia, the item in Bahasa Indonesia, and translate with the same meaning with the local language. So it's one, the alternative, compared to we have to build the new instrument for Sunda, new instrument for Java. We need money and then also time for do to that.
But it would be your ideal solution, when I hear it correctly.
Yes, it would be, yeah.
Yeah, I think so.
Okay. These questions were, of course, only meant to show my interest in your very interesting thesis, and I give the word back to the rector.
Terima kasih.
Thank you very much.
Sama-sama.
I now call upon Professor Buskens, Professor in Health Technology Assessment and Faculty of Economics and Business.
Esteemed candidate, my sincere congratulations that also I would like to extend to your family, friends and your promoters. You've done great work. I think it will be very important once you go back, because you apparently have become not an academic and a scholar, but you've become a civil servant, so you're actually going to serve your population with a PhD now. That's great news, I guess. But I also noted that you go up steep hill, because that's what your cover says, and it's seemingly without effort. I take it that you're very ambitious, and I would very much like to look into your ambitions with regard to public health. This is where we switch to the actual content and my questioning. So it apparently is that low and middle income countries, there's an epidemic of obesity and subsequently diabetes. And many people feel that this is a worry, although what you have also shown is that many people only discover by the time it's far too late. Their disease has progressed, they also get secondary problems like kidney, high blood pressure, whatnot, and maybe blindness occurring, and only then they discover. And of course that is a reason for lots of distress. So in chapter 2, you specifically look into the distress these people experience with your distress skill just discussed. What would you think, looking at your results, causes the most distress amongst the population? What would be their sort of most worrying symptoms or effects that diabetes has on their daily activities and their mental well-being? Could you elaborate?
Highly learned opponent, thank you very much for your questions and also your compliments. It depends on the characteristics. For the younger participants, they're more distressed in their emotional burdens, because for young people living with diabetic, they are distressed about their future life and their future career. But if you compare with the elderly, they say, oh, I'm old, and then diabetes is, yeah, no problem, and then I'm still waiting for many years to die, something like that, compared to the young people. And then, for your next question?
Well, so your answer was that younger people, they fear the disease and its complications, okay. And older people apparently fear other factors, like okay. They've got to have diet, they've got to start exercising, those kind of things. This is what I took from your yeah. chapter 2. Yeah. Is my assumption correct, that these are the most sort of challenging issues they encounter?
Yeah, you're right.
Okay.
And then can I continue?
Yeah, go ahead.
Okay. For some participants, they also tell to me, as researchers, about the diet, because sometimes they do not understand what kind of food they have to eat and what kind of food they have to stop eat. But for Indonesian, it's almost impossible to not eat rice, because we eat rice every day. And but also some participants stress with the physician distress.
Yes.
Physician distress in Indonesia, for the diabetic patient, they thought that diabetes needs specialization for them. So when the patients visit the health facilities in primary care, and then they met GP, general practitioner, and say, oh no, diabetic is not for the GP, but it's for the resident of internal medicines. So most of them, if they are diabetic, with severity, they will ask the GP to give a referral letter, and it's common in Indonesia. So, yeah, I think it's also if we compare the original diabetes distress, Professor William Polonsky only divided person with diabetes physician distress, but in Indonesia it's different. What kind of physicians?
I read that also the type of physician they get referred to or stay with the general practitioner, that also causes some form of distress.
Yeah.
That's clear to me. I would also like to move on to chapter 3 now, because at some point you conclude that one of the solutions, because it's clear that it's becoming an increasing burden, it has become, and that it will be increased further, type 2 diabetes. One of the solutions you propose, and you're becoming a civil servant, so I take it that this is something you would like to implement, is to implement screening. So then the question becomes, what are you going to screen for? With what instrument? Can you elaborate there? What do you think you should be screening for?
Okay, thank you. Yeah, it's one of my next plan. It's the screening test for Indonesian. Which instruments? I think I will use my diabetes distress scale instrument for the screening for diabetes distress. And also, I think I will do the next translation, revision, and validation study for the screening instrument.
To avoid the burden of disease, to further increase, that screening with this instrument will help? Or do you think you should start screening for diabetes as disease as such?
We can do it both. So screening for the diabetes and then also screening for their distress. But for diabetic screening, I never found the screening test in Bahasa Indonesia. But I read many screening tests for the Australian screening test for their instruments. And then I would love to also translate into Bahasa Indonesia and validate that instrument that we can use for our next screening project.
Is there still some time left?
I'm afraid only very,
Very short.
very for sure.
Okay. So I have a suggestion for you. If you start screening, you will find people that have diabetes or pre-diabetes. So their glucose tolerance has decreased. The distress they will encounter subsequently after becoming screen positive is severe. The same distress, diet, physical exercise, and managing your own health would occur had they gone back in time and managed their health properly. So rather than putting the horse behind the cart, as we say in Dutch, or the cart before the horse, as the actual proverb in English would be, would you not prefer to have some sort of lifestyle intervention implemented?
Yes.
Can you give a very short
Okay.
answer?
Yep.
I will health promotion for the Indonesian participants. We will do it in the simple way, something like this. If we health promotion, sometimes we distribute the brochure, but I think it's better like this. It's like the medicine bag, their medicine they can have here, and then we can write our, like, don't forget to take your medicine, don't forget to take something. It's more useful for them, and they will remember everything, every time compared to the brochure.
Okay, thank you very much, and I'd like to return the word to the director.
Thank you very much for your question. I will now call upon Professor Atobari from the Gadjah Mada University of Indonesia. Very welcome and nice that you undertook the whole journey to the Netherlands. You are also his co-promoter, and I give you the word.
Okay. Thank you, Madam Rector, dear esteemed PhD candidate. First of all, I would like to congratulate you for this good thesis and very beautiful book. I really enjoyed working with you, especially supervise you during your data collection in Indonesia. As you know, the topic of the quality of life in diabetic population in Indonesia is very important at this moment, because Indonesia have a double burden of diseases, both communicable and non-communicable at this moment. And diabetes is one of the diseases with the high prevalence in Indonesia. The last report that I read in 2015 reported we have 7% prevalence of the population above 30 years old, and that quite high. And not only that, but the mortality and caused by its complication is also very high. So since 2014, we have a universal coverage system. And then in 2017 itself, the diabetic, it's now the third rank for spending budget in Indonesia. So this is very high burden. And I have discussed with many doctors in Indonesia, quality of life is rarely measured in the clinical setting. Only cancer patient that they're concerned about the quality of life, but not in diabetic patient. Now, I like to ask the question is, what are the implications of your study for our policymakers and also for clinicians especially, and for all healthcare providers in Indonesia, and how this measuring of quality of life would integrate it in the clinical setting?
Hello, and opponent. Thank you very much for your compliments, for my cover, and also for your questions. I think we will, to communicate with the physician in Indonesia, we can start with the simple thing, like we discuss about the evidence-based medicine about the quality of life study in Thailand or in Singapore, and then what is the impact to the diabetic patients. We can start with the simple things, because I also did it when my data collection in Mowardi, and many internal of resident medicine and a professor in that hospital also interesting for the quality of life study. And then you're right, for our study for in the health field, it would be nice if we can apply for the clinical settings. So back to my first answer, how to apply it, communicate with the doctor. And then, yes, thank you very much. I also highlight that in Indonesia, the HTA guidelines 2017 also highlight about the data for Kali data. So my study is the first study in Indonesia. So I'm really sure that we will use the utility score for the pharmacoeconomics analysis, and then it's really important for the policymaker in Indonesia.
Okay. In our study, in your study, it's shown that primary health centers and the secondary health center have a different in terms of score of quality of life. And do you think the screening of using the quality of life measurement as an indicator as a clinic is important?
Yes, it's important.
Why?
It's important. Yes, because in my study, in chapter 6, the utility, we find that participants in primary care, they reported higher utility score compared to those in secondary care. But I think it's same with our expectation, it's same with our hypothesis that we proved that. Is it your question?
Yeah.
Yeah, and then yes, also for the screening for quality of life in type 2 DM, it's also important because if you see the data, patients with complications, they decrease their quality of life. So compared to the healthy patients. But I think it's also a good news for the researchers. Like I have many experience. Like I have 2 participants, the healthy diabetic patients and then the more severe diabetic patients. For the more severe diabetic patient, it's more willing to help the researchers because they would like to express their feeling living with type 2 DM compared to the healthy diabetic patients.
Okay. Do you have still time?
We have still a little bit of time, yes.
Okay. My next question is related to the chapter 6. You did the study in small part of Sulawesi and also in Java. And how could your study be generalized to the rest of diabetic population in Indonesia, since we have diverse, different on the population, infrastructure, and also healthcare system across Indonesia?
Thank you. You're right. I think for every study, they have limitations, also for my study. And to generalize is the big challenge. Also for the RCT, also it's big challenge for generalize the result to the populations. Yeah. I also reported that one of my limitations is to generalize, but I think at least I have 2 sites in my study. The first site, our data collection in Sulawesi. Sulawesi is representative for the western part and the central part of Indonesia with the limited health facilities, limited access to the medicine with the patients. So it's representative for that. And for the Java area, it's representative for the western with more better health facilities. As an illustration, diabetic patients living in Banggai Laut is a remote area. When she visits the health facility, she needs to at least 100,000 rupiah for the transportation cost. But for the diabetic patient living in Jakarta or Jogja, they only need 10,000 only for the transportations. So it is also, it's also nice to elaborate more about the cost of diabetic in Indonesia.
Okay. Thank you for your, Madam Rector.
Thank you very much, and also, again, thank you very much for coming here. Then now I now call upon Professor Katja Taxis, the Professor of Pharmacotherapy and Clinical Pharmacy of the Department of Pharmacy Groningen.
Yeah, thank you. Thank you, Rector. Esteemed candidate, also my sincere congratulations for this beautiful thesis and for working in a very, very important area. We heard already many of the difficulties of diabetes patients. So congratulations for this. And hopefully your thesis will contribute to develop better healthcare quality for diabetes patients. And my first question is also a bit more general. When I look through the characteristics of all the study samples you had in the various chapters, I see that the percentage of patients with complications is very high. 1 or more, or even more than 2 complications, diabetes complications, is very high. So I think maybe this is one of the biggest messages of your thesis, But I was wondering whether is there in Indonesia more data on this general data, prevalence. We heard about prevalence of diabetes, but also prevalence of complications. Does your study compare with those, or is there other data has looked at that?
My highly land opponent, our study, my data is I did not compare with other data.
Not comparable.
No, not compare with. I did my data collection by myself. I only compare the data like primary and secondary, but I did it all my data collection by myself.
Yeah, but have other studies looked at the rate of complications of diabetes in Indonesia? Are there other studies?
Yeah.
Okay.
Yeah.
And do they have similar rate, higher or lower, or similar rates like yours?
A bit similar, because I went to annual pharmacy meeting in Riau, and I was surprised because one of the researchers from the Universitas Gadjah Mada also present the results about the quality of life and type 2 DM outpatients. And then when I discussed with her, yeah, we have a similar result, quite similar result. In my result, for example, I found that age do not influence the utility score. Also in her research, also state the same like my research.
Yeah. And did she also look at the number of complications in patients, in diabetes patients, like amputations or blindness or?
Yeah, we look at you mean the detail, like hypertension, myocardial, yeah. We look at that, but when we try to subgroup them, it is only limited number, so it's not comparable for the further analysis. Yeah. So I just classified them 1 or 2 more complications.
Oh, okay, yeah. And when you look at that data, is it comparable to data, if you compare your rates to, for example, countries like the United States or to the Netherlands?
I don't know.
Yeah, okay, yeah, we'll go on. And then I want to ask a few questions about chapter 3, your qualitative study. Yeah?
Yeah.
Okay. I was wondering why you did that study in chapter 3, because you used an existing questionnaire and then you did a qualitative study using a questionnaire. And most of the times it's the other way around. You do a qualitative study and then you develop a questionnaire. But you use the questionnaire to do a qualitative study. So I was wondering, why did you do that study?
Oh, okay. Thank you. I did the study because in my future I would like to concern in distress and then also the quality of life in Indonesia type 2 DM. In total, in my thesis, there is 3 chapters about distress, diabetes distress. The first is translation and validation. The second is the qualitative study, and then the third is the modeling study. Why I did the qualitative study? Because I would like to know, I would like to explore more deeply what Indonesian patients feel about their diabetes distress. So I would like to know comprehensively for the diabetes distress situation in Indonesia.
Okay. And what things do we learn from your study that we can't learn if we just distribute the questionnaire?
I think when you did the qualitative study, you will feel, for me, I feel the empathy, something like that, and then we will get more rich data. For example, for the diabetes distress scale, it's only 4 domains.
Yeah.
But after I analyze my data, for the Indonesian type 2 DM, they are also distressed with the Indonesian bureaucracy.
Yeah.
So it did not present from the previous study conducted in China and Denmark, and also the original study, yeah, something like that. And then also, yeah, we find that Indonesian patients more comfort if they consult with the resident internal of medicines, internist, compared to the GP. And also, our finding, it did not present from the previous study.
Okay, but does that mean that maybe the questionnaire should be changed, adapted, to make it even more fit, based on your qualitative study, to make it fit the Indonesian healthcare context?
Yes, I would love to do that. Also in my mind, I would like to do that. But we have to take into account that at the moment, our questionnaire is 17 items. And then when you distribute the questionnaire with more than 17 items, they will say, oh, no, I don't want to participate in your study. So I think the challenge is I would like maybe to discuss with Professor William Polonsky about our finding in Indonesia. And then for your suggestions, we divided for participants in secondary care with the internist, and then participants in the primary care with the GP, how they are distressed.
Yeah, okay, good.
Oh, some 15 seconds.
Short question left.
Maybe a short question about in your chapter 3, you also make some quite firm conclusions about the problems of housewives. But when I look at the inclusion, there were only housewives included, no other female. So I was wondering, is it valid then?
Okay.
Or or why was that?
Okay.
Maybe we start with that. Why? Okay. Why did you not include other females, working females, for example?
Okay, thank you. We did send an invitation to all potential participants. The first inclusion criteria, all the participants we type to DM, but only 41 willing to participate in our FGD, and 2 participants, we have to contact them, and then they say, okay, I would like to participate, but you have to visit me in my house. And it's by chance, it's not in purpose that we would like to have the housewife. No, we send our invitation to all females, but only housewife interest to participate. Why? I think because housewife, they have more time to, compared to the career woman in Indonesia. And then in Indonesia, for the housewife, usually they only take care to her husband and her kids. And then for the invitation, it's something special. Oh, I would like to go there because I would like to meet the doctor free. I would like to meet my friends with the same condition. So that's why housewife is mostly housewife in the chapter qualitative study.
Yeah, okay. Yeah, so maybe in future you can extend it.
Yeah.
Okay, thank you. I'll give back the word to the rector.
Thank you very much. Then I now call upon Professor Wilschut, Emeritus Professor in Molecular Virology of this university.
Thank you very much, Madam Rector. Esteemed candidate, let me first congratulate you on the completion of this thesis and also include your supervisors in this. Congratulations. I was intrigued by the cover of your thesis, by the double cover, in fact. First, it's very modern. It's a selfie of the author in front of the Borobudur, if I'm correct. And then secondly, it is interesting. Opening your thesis is sort of a process. So it's a 2-step process. It's like a journey, if you wish. A journey from Indonesia to the Netherlands. And there we see quite remarkably that the Dutch equivalent of the temple of Borobudur is the stadium of the local football team. And here I sense the influence of your promoter, I believe, and maybe also of your second paranymph. But it might be that I missed some of the symbolism. So perhaps there is there is more into the cover than meets the eye, and perhaps you can give some additional explanation on the cover of the thesis.
Highly learned importance. Thank you very much for your compliments about my cover and then for the confirmation about the story. That you're right. In my cover, in total, I have 2 stories. The first cover is the Indonesian story that I come from Indonesia. And then, yeah, many people, they know about Borobudur. That's why I present Borobudur here. And then if you look at here, is it the cardinal fish? And then that fish is only found in the remote area in Banggai, Laut, Central Sulawesi. So it is also represent that I come from one of the remote area in Indonesia. And then here, when I come in the Netherlands, I only bring 1 suitcase, and with the LPDP scholarship in my bag. So, and also the Indonesian flag, it means like I follow to the Indonesian regulation. But if you compare with this, it's not only 1 case here, but also 7 chapters. That means I have to finish my PhD with 7 chapters at least for my thesis. And I changed the flag, not the Indonesian flag, but the Dutch. It also means that I'm here, I have to follow the rule in the Netherlands. And about the FC Groningen Stadium, you're right. Because here, to be honest, my professor and also my co-professor, co-supervisor, they helped me a lot for that thing.
So you honored them?
Yes,
by
yeah,
this.
I honored them.
Okay, I appreciate that. Okay. Now, what probably will happen, and I already noticed in the hall, is that people will just throw away the first part because it's too complicated every time when you open the thesis. So you end up with this situation. Is that intentional?
No.
In other words, do you see your future in front of the backdrop of the FC Groningen Stadium?
Okay. I see my picture because I would like to continue my study working with the University of Groningen. And I really like to live in Groningen with the
And
students.
occasionally you will attend a football match then?
Yeah.
Together with your promoter? Yeah. Okay.
Yeah.
Thanks very much. Let's get a bit more serious then. Way back, I'm trained as a biochemist, and then I learned a little bit about diabetes mellitus, and you indicate in your thesis that the incidence of diabetes increases very rapidly in Indonesia, much more rapidly than, let's say, the average worldwide increase. Is there any specific reason that you can indicate that that might be the case?
I think
Or is it just improved registration?
Oh, okay. I have 2 questions for, I have to answer for your questions. The first, it's about the Indonesian lifestyle. And in the second, in Indonesia, we start our universal health coverage since 2014. And then at the time, it's the promotion like, if you go to if you visit the health facilities, everything is gratis, everything is free. So maybe before that programs, for the diabetic patient, they only stay in their house because they thought about the diabetic cause. But after 2014, they visit the health facilities and then they register. That's why it's increase for the number.
You also indicate that it is not only in the elderly population, but also among younger people that you see an increase in diabetes type 2. And I've always understood that this is really a disease that is related to aging, receptors for insulin becoming less and less sensitive for the hormone. What could be the reason that you also see diabetes type 2 now in younger people?
The reason is, I repeat again, it's lifestyle. And then at the moment, everything is easy. Like you can order your food by telephone. In Indonesia, we have Gojek or something like that. So they less time to exercise.
Yeah.
So less time to walking to go to the restaurant or cafe to buy the food.
Accelerated aging, so to speak. Yes. Okay. All right. There's very little time left, but let me just try. I've been collaborating with your promoter many years now, and I've enjoyed it a lot. And one sort of big parameter in all these studies that we have encountered is the ICER, the incremental cost effectiveness ratio in health economic analysis. That is, for a certain intervention, you pay a certain sum of money, and then you look at what the gain is in terms of this sum of money per quality adjusted life year gained. This quality adjusted life year, of course, has to do with the quality of life, and these health economists, they always like to work with rock solid numbers, but this denominator, the quality adjusted life year, is not a rock solid number. If I read your thesis correctly, particularly chapter 6, where it shows that housewives and people of low education and lower socioeconomic status, they perceive their condition differently from others, and they think they're worse off. In other words, this number is not a rock-solid number. How should we deal with this now? Yeah, I was afraid this would happen. So, maybe we should continue. Well,
We can
it's up to
continue
the
this.
rector.
Yeah.
Okay.
I think we should continue the discussion during the
Okay.
reception. Thank you
Okay.
very much.
Okay.
The College of Deans will withdraw for some time to consider its decision.
Satu, dua. Ya. Satu, dua.
Esteemed PhD candidate, the College of Deans of this university, represented by us, after reading your PhD thesis and accompanying propositions, and after hearing you defend them, has decided to award you the PhD degree that you desire. Your primary supervisor, Professor Posma, is authorized to award you this honor in the customary fashion.
I am honored to accept the task assigned to me by Madam Rector Magnificus. However, before performing that task, I would like to address a few personal words to you, Uri. I all the time said to you, try to enjoy the defense as much as possible. And of course, that's easier said than done. You were supported by 2 great secondants today. I think that really helped the A team, let's say, huh? Both names with an A. And it's done. So for a moment, cherish this moment. I mean, it's a unique moment. Huh? So that's the first thing I wanted to say. So let's cherish this moment. The other thing I want to say, be not disappointed when my speech might be a bit shorter than some other speeches that you've heard before, because very fairly, I was said last Monday that I over-timed my speech 100%, and it was said so nicely by the pedal to me, your colleague, that I cannot not take that into account. So I will leave some things for tonight when we have our party at the Pluto Zaal and the Pluto Laan, where you lived 4 years long in Groningen, the Pluto Laan. So this is the 5th pharmacoeconomic health PhD, health economics, pharmacoeconomics PhD defense in Groningen. Some of you in the room on Monday may think, huh? Did I lose counting? Because Monday I said 3, the 3rd, nearly. And what about number 4? Now, actually, Monday I forgot Professor Yarir, who was actually the very first health. So apologies for that I forgot you on Monday, Professor Yarir. Great that you are here today. Professor Yarir supported you. Paul Krabbe, who is also co-promoter, but could not be here today, supported you. Many people seem to find a joy in supporting you. I think you have that natural charm that people like, don't mind to help you. And just to mention a few others, Chi, Thea, Nienke, Lucy, and I can go on. We even had to disappoint some colleagues today. Christine would have really loved to join this event today, but it was not possible. Foremost, you were helped, but foremost, you did it yourself. You managed your whole project yourself with a lot of creativity and flexibility. You were supposed to get data from the BPJS, the National Health Service that you referred to in Indonesia, but actually you didn't get them, and you had to rethink, we had to rethink, but you did a lot, you did it mostly yourself, everything. And the good thing of that, you could design your study completely in line with what where your strengths are. You interviewed patients, qualitative research, you did field research in hospitals, Sulawesi, Java, and major interest in quality of life and diabetes distress scales, as we heard today. And I think you are at your best when you are close to the patients, rather than having loads of data. You want actually to see the faces behind those data. Now, Uri, from Luwak on Sulawesi, as said, as you always say to us 1,000 times, the remote area. Now, what does Wikipedia say on Luwak? It doesn't sound so remote to me even. I mean, 50,000 inhabitants is not too bad. You have an airport, and it's not one, but you even have 3 different ethnic groups over there. So, but it is the remote area with a nice beach. That's also what you find immediately when you go to Luwak. The Palau Kilo Lama. I would love to come there once on the General Sidoerman Coastal Road. I won't mention General Sidoerman here in the Netherlands. Maybe we have some history there. You did a Bachelor of Pharmacy at the University Makassar. You are apotheker, and that's Bahasa. That's also Bahasa, apotheker. Yeah, I speak a little Bahasa as well, Bob. Cum laude Master Biomedical Sciences, Gadjah Mada, and second Master even in Hospital Management, also in Gadjah Mada, Yogyakarta. And then the LPDP funding to come to Groningen. And did I mention already that you are the first LPDP? I didn't mention it yet, huh? No, you are the first LPDP awardee to get your diploma in Groningen. We really enjoyed this issue of thinking about words that are the same in the Netherlands and apotheker, gratis, stuur, pedaal. So of course Bob laughs about this, but that's clear. But we enjoyed these words that are the same in the two languages. Of course, I have to briefly mention FC Groningen, already so nicely. And you joined twice, I think. And was it because you thought it is obligatory when you... But you were right, it is. or you didn't want to offend me and say no. Or otherwise you wanted to please me, I think. Because your real sports, you don't have that much with football, soccer. Your real sports is badminton. Like many others in Indonesia. So my sincere apologies for forcing you into the Euroborg twice. The Groens Cup is the annual major event in badminton for Indonesian students in the Netherlands. And you won the men's double in 2016. And you reached the finals, but unfortunately lost. But still, second place, men's single in 2017. And you once told me, what is so important with badminton? Technique, of course, but what it's all about is emotional control. And I know you teach some of the others, even Matthijs is in the room, and you teach some of the others your skills in badminton. So you're also an excellent badminton teacher. And now I think my 6 minutes are getting to press, and I don't get a signal that it's different, so let's go to my last point. It is a day of joy, but also a bit of remorse. A period of 4 years comes to an end with professional work, wonderful interactions with the colleagues, nice social events, a lot of fun and some nice trips. You were a wonderful host recently in Indonesia, a memorable stay with scooter trips, rice fields, Ubud, Kampuchean, a rich walk. I will say more about it tonight. But now, it was all quite pressing in the end. Your visa ends and you go back to Indonesia. I am sure you will keep up the good work in Indonesia, and preferably still with me included. And we have, of course, the European Union proposal, the Sunny Sea, that we do together with Jaap. And who knows? Of course, you have to be a bit lucky in those things, but who knows? And anyway, you are creative, so we will always find ways to cooperate. Okay. Now, luister goed. Saya megayak anda semua untuk berdiri. Heel goed.
All understand.
You understood? Yes, very good. By the virtue of the powers vested in us by Dutch law, in accordance with the decision of the College of Deans of this university, I, Maarten Jacobus Postma, confer on you, Arifin Bustanul, going by the name of Uri, the title of doctor and all the rights associated by Dutch law or custom with a PhD degree at the University of Groningen. Do you as a doctor promise to act in accordance with the Netherlands Code of Conduct for Scientific Practice?
Yes, I promise.
You can take your seats. Now that I have performed this task, let me be the first to congratulate you with the doctorate that you achieved.
As proof of this PhD degree, I will present you with a certificate signed by the Rector Magnificus, by the Secretary and the supervisors. And it's sealed with the Great Seal of the University of Groningen. But before doing so, very learned sir, it's my pleasant duty to congratulate you, also on behalf of the College of Deans of this university, on the degree that you have been awarded. I now declare this ceremony for closed.